I'll show a few cases. Let's see here. So let's start with this one.
I'm on now.
All right, great. So this is,
Go ahead.
I haven't shown the images yet.
No, that's fine.
Here. Make sure I get the right ones. All right, so let's see, show. All right, so you should see a portable radiograph. So this is a middle-aged man who is a kidney and pancreas transplant recipient who developed fever and cough. So this is a portable radiograph that showed some abnormality in the right lower lobe. Hard to say much, but then had a PA and lateral radiograph 5 days later. And those show much more sort of nodules in the lungs and some denser consolidation. We look on the lateral, you see some lower lobe consolidation, questionable effusion, but this sort of background of nodules. So when I see nodules, large nodules that I can see on a radiograph, of course, I think about fungus. So this is his CT scan. And it was done this about the same time as a two-view chest. And you can see there's all these nodules, small, large, and then he has this denser mass-like area of consolidation in the right lower lobe. Conspicuously, no pleural effusion, and really not much in the way of really no lymph node enlargement. So I do think about fungus when I see this, particularly this combination. And he ended up having blastomycosis, which I've shown you guys several cases of. So the things I've noticed with blasto is you often get large mass-like areas, and in the transplants, we see about the same extent of disease, but we tend to see more, seems like more of these disseminated nodules. But we usually don't see much in the way of pleural effusion. He has a little one here, and much in the way of lymphadenopathy, because it usually stays confined to the lungs or gets bloodborne, can get to the brain, bones, skin. And I can't remember if this guy had skin involvement or not. I think he had something on his skin that was questionable. So that is one case of blasto. And then, because we like to see more blasto, this was a follow-up. This one's a little more interesting, so I'll show the radiograph. In that this guy, I've never seen this happen with blasto before. So this is a radiograph from this week. And you can see he's got some scarring, volume loss on the left, and a bunch of nodules that are fairly conspicuous. There are probably some calcium in it. And I found a CT from 2015 where he was acutely ill and had these large nodules. And throughout, kind of looks like our last patient. There's some scar down there. So this time, he actually had active blastomycosis at this time. And usually when it goes away, it goes away. But these nodules persisted over several years. So here's 2017. Earlier this year, and some of them even had cavitated over time. And this was developing some mineral in it. So sort of a, like more typical we see with histo, where the nodules don't always go away, they just calcify. You can see this one here as well, developed some mineral around the outside. So this was a bad blasto case that didn't radiographically clear, but he improved and his antigens turned negative. They use a urine antigen. They treat them usually for 9 to 12 months with an antifungal. I think itraconazole is the one of choice. And this is sort of the sequela. So this is the first time I've seen blasto leave nodules behind, and not so I thought that was kind of interesting. So those were two cases of that. Now this is the case I sent around to you guys that we've talked about over here for a while. So this is I have very little history other that this patient had an ascending aortic repair in 2005. And you can see there's a graft there and no symptoms as far as I know, but there's this collection here. This is recent imaging, and then this funny filling defect that appears to affect the right pulmonary artery. And I'll put a sagittal up. There's the corona. And Seth had said he'd seen this before, right there. And because we were wondering, was it a pseudoaneurysm that was eroding in, or is it just some of this collection indenting on the pulmonary artery? So yeah, we talked about it a little bit more. I think we're going to do an MR here just to prove this thing isn't delayed enhancing or some sort of vascular communication. It doesn't look like thrombus, and it doesn't look like a tumor. I only have 2 months worth of CTs that shows no change over about two-month period. But I was just curious, Brent, you're online, if you'd ever seen something like this, or anybody else.
So
Jeff, is your presumption then that this is part of the pseudoaneurysm that just is mashing into the pulmonary artery?
Yes, or if it's really a pseudoaneurysm, or if it's just this kind of, let me get the, I forget, this always shows only one series. If it's this perigraft collection, valve, this collection right here of fluid, because thinking about it, of course, the ascending aorta and the pulmonary artery share an adventitia. If some of this fluid just sort of undermined or dissected along here at some point in the last 10, 12 years, this may, for all we know, this could have been sitting here for a long time and is sort of just indenting on the pulmonary artery.
Mm-hmm.
But it seems to communicate with this fluid right in here. So that's what we're thinking. But we decided we would do an MR just to prove that it's not leaking somewhere, to also characterize this stuff around here, around the medial and posterior aorta graft. But I don't know. I don't know what it is, but it was bizarre. But Seth said he'd seen it about 3 times, and they never had proof of whatever it was, but that was his thought. I know, Brent, have you seen something like this? I know you guys see a lot of aortas. I think we've lost Brent. Okay. Well, I'll bring it back up if he comes along.
Jeff, your screen has disappeared.
Yes, I turned it off.
Okay.
Let me, I'll stop. I'll do this last one. If there's time, I'll show it. So this is a young man who has a history of ulcerative colitis, and he came in at this time with a cough. And you can see he's got these sort of subtle opacities, not quite nodules in the lower lobes, not all that exciting looking on the chest radiograph, but it wasn't quite normal. And they did a CT a few days later, and he's got sort of these peribronchial foci of ground glass. And yeah, you should see my CT. And sort of these nodules with little halos around them. But they're very airway centric. As we go further down, they become a little easier to see, patchy ground glass. So the question of infection was raised, of course. At this time, he had been off his TNF-alpha inhibitor. And other possibility, of course, would be some organizing pneumonia from drug toxicity or his UC alone. So he had a full infectious workup, and nothing came back. And really, they did a pretty good job, did bronch BAL, some transbronchial biopsies. So this all responded to steroids. I don't have any follow-up imaging on him, but this was all organizing pneumonia, thought to be a manifestation of his inflammatory bowel disease. I don't know if he was using any illicit drugs like marijuana. I know it's common in some of these patients, but it can manifest as a lung involvement. And he responded to steroids and hasn't recurred since. So just a case of inflammatory bowel-related lung injury. Okay, I'll show some more later if there's time. David, do you have cases, or Howard?
I have 2 related cases to show. Can people see a radiograph?
We do.
Mm-hmm.
So this man is about 65 years old and has a history of rheumatoid arthritis, has this chest röntgenogram here with lots of interstitial abnormality here and a sort of bubbly look in the bases down here, but preserved lung volume, surprisingly. Now, he had been a cigarette smoker until a year before. He does have a history of rheumatoid arthritis. He's had this lung disease for several years, and it's presumed to be related to his rheumatoid arthritis. His rheumatoid arthritis is not erosive, so he doesn't have a lot of bone findings. He's got some degeneration, but that's about it. So he had a CT scan, and it shows that these lungs are abnormal. We have this pattern that was called honeycombing. You can see he's got these stacks of cysts out against the periphery. But what struck me about this is the amount of upper lung involvement. Seems to go all the way, almost over the apices here, over the apex on the right and almost on the left. And then the very thin-walled nature of these cysts here. So it looks to me as if there are these holes in the lung, but not a lot of fibrosis. So it doesn't look like an ordinary UIP because, you know, we're not seeing a lot of reticulation. We're just seeing these holes in the lung for the most part. So I was a little stymied by the radiographic appearance here. The other thing is that I've seen a similar pattern to this in people with sarcoidosis who go on to get so-called honeycombing. It often has very thin walls. It's often upper lung predominant along fissures and things like that. And so a very similar pattern of very thin-walled cysts that you want to call honeycombing, but they're not in a matrix of fibrosis the way that honeycombing usually presents in the setting of UIP. So our pathologist, you know, did some extra work when this man came to lung transplant. And let me see if I can show you the path here. So he went back and did a whole bunch of extra staining here, and I've just copied the path report here. So these last three paragraphs are the most helpful, I think. This cystic abnormality and fibrosis, quite unusual, more consistent with extensive confluent bronchiectasis than it does with fibrotic honeycomb spaces of UIP. So his path assessment is similar to the radiographic assessment. Cystic spaces are internally lined by ciliary respiratory type epithelium, implying that these are airways. These holes are lined by airway mucosa. They're smooth muscle cell. And then he pointed out that this man has pulmonary hypertension, and he did have a dilated pulmonary artery on the CT scan I didn't point out. There's a lot of hemosiderin-related macrophages from reflecting hemorrhage, interstitial hemosiderin deposition, and iron-encrusted elastic tissue. So Rod Schmidt, the pathologist, points out that when you have iron staining elastic tissue, macrophages will treat that as foreign tissue and will eat it up. So that might be a way to get emphysema in this setting, or destroy things like alveolar walls and create these bigger spaces. So the latter frequently have an associated multinuclear giant cell reaction. So these giant cells would be particularly, they might be prone to eating this elastic tissue. So well-preserved areas of the lung show little convincing evidence of pulmonary hypertension, but he did have it clinically and dilated main pulmonary artery. So unusual form of interstitial pneumonia, but we don't have a specific disease name for this entity. So he proposed calling it Schmidt's disease. I don't know where he came up with the name Schmidt, but Rod Schmidt's a very good pathologist, and he's now emeritus, so he deserves to have an entity. So I tried to find a case of sarcoid with a similar thin-walled cystic abnormality that you at first think is honeycombing, but then doesn't have the fibrotic matrix around the holes that you would expect with the typical honeycombing. And I didn't find the best case, which is out there somewhere, but it wasn't in my database to retrieve easily. So here's a woman who has known sarcoidosis for many years, pulmonary hypertension, and an upper lung predominant interstitial abnormality and low lung volume. And this is what her CT scan looks like. Again, she has fairly similar thin-walled cystic abnormality here. It doesn't look like a lot of fibrosis, but we have these thin-walled cysts. And then she also has a lot of traction bronchiectasis. She's got these dilated bronchi, this sort of varicoid pattern of dilated bronchi that seem to go out to this. So, you know, there seems to be an airway component to this, and I wouldn't be surprised. She didn't have path, so I can't establish this. I wouldn't be surprised to have a similar path findings on this case had she ever had the biopsy. So this honeycomb-like pattern that's not really honeycombing in terms of having thick walls, fibrotic walls, and a fibrous, you know, a reticular pattern around the holes in the lung. I'm still going to look for that sarcoid case that's more dramatic than this in terms of having an abundance of thin-walled cysts that lined the fissures and so forth, but predominated in upper lungs, that has that bubbly lung, that bubbly look of the first case. So Rod was thinking also that there was a component of emphysema with this when we talked. So with the first case that had path. So I think not everything that looks like honeycombing really is honeycombing, and I think we ought to designate a thin-walled cystic abnormality that doesn't have other features of honeycombing and consider that pathologically separate. And so far I've seen that in sarcoid advanced cases of sarcoid, and I've seen it in this case of rheumatoid arthritis. And now that I'm alert to it, I'm going to see if I can find it in more cases. So pseudo honeycombing right now is what I'm calling this, or bubbly lung disease. I don't know. I welcome any input, or if you guys have cases, and maybe we should mobilize cases if you have similar ones, and let's get this entity out there or something. We have patho on at least one now.
We had a
I definitely have one case that I can show at a later time.
case yesterday of a scleroderma patient with an NSIP-looking lung, but had some similar, but even thinner wall bubbles in the upper lobes anteriorly, kind of away from all the other stuff.
Mm-hmm.
Makes me think about that. We should call this champagne lung.
There you go. That'll get it published.
Yeah. Here we go. All
Okay,
right.
those are the cases I wanted to show.
Thanks, David. All right, Howard.
Okay. This week I'm going to show some cases that a colleague from London, Mary Roddy, at Imperial College has shared. So thanks to Mary for these cases. So let me show you the first one. This is a patient that at a point in time sustained trauma. So this goes back to 2011, at which time you can see at least one rib fracture and adjacent lung opacity, quite consistent with contusion. This is a CT from the same time. What's partly interesting about the CT here is the appearance of this seemingly a mass almost in the central part of the right lung, right infrahilar lung with pleural fluid with the trauma that, as you'll see, subsequently did resolve. So that was presumably a focal area of contusion in that particular location. So that was then, and now I'm going to show you a radiograph done in December of 2016. This is actually a spine. So you'll see here there is an abnormal opacity with a convex interface with adjacent lung in the basal right hemithorax, partially imaged, of course, to get the feel for where it's located in that basal right hemithorax. And next I will show you a chest radiograph from more recently. So this is one view showing that large opacity in the basal right hemithorax. And now I'm going to show you a really nice image, which this is going to be a coronal just to go along with that, that shows that this is a traumatic injury to the right hemidiaphragm. And you can see where the liver herniates through the diaphragmatic defect into the basal hemithorax. I'll put this axial projection alongside it. So for example, if I were to pick that spot here on the coronal, you can see what it corresponds with on the axial view. And similarly here, say in this area, it corresponds in location to this area on the axial view. So we can see where the diaphragm is still intact and impresses on the liver, which is herniated through that defect. And you can see that this is mostly in the basal and lateral chest in that location. So a really nice example of a traumatic injury to the diaphragm with the herniation occurring over time. So the initial injury, 2011, and then these more recent findings became apparent in 2016 and imaged again. So a nice example of that. You can see here posteriorly that portions of the diaphragm are, if I can get to the right place, are intact, like here anteriorly and here posteriorly, but it's focally over here where the injury is, posterior and lateral. So a nice example of that. Here is a case of a person that develops over time a fibrosing interstitial lung disorder. So on the left we have March of 2009, February of 2017 on the right. You can see there are reticular nodular opacities in the lungs. One can see diminished lung volumes consistent with a restrictive lung disease. And then if we look at the CT and the appearance and the distribution of the opacities, because it's not particularly suggestive of the usual ones we think of. So there are coarse reticular opacities, there are subpleural. Clearly the upper lung zones are particularly involved, and right up here there are opacities that reach the pleural surface. So the diagnosis here is, and I believe, I'm not sure if it's based on a lung biopsy or just a combination of clinical and radiographic findings, but I think certainly consistent with so-called pleuroparenchymal fibroelastosis. So obviously not in the context of lung transplantation or stem cell, but just a person that developed this sporadically. And certainly I think the imaging findings are very consistent with that form of fibrosis.
Howard, you also wonder if this patient was an aspirator given the airway-centered stuff and the quasi-abnormal esophagus. Look at those airways in the lobes.
Oh, so for example, up here.
Right, they're thickened, and there's some bronchiectasis in the middle lobe, the lingula.
Yeah, there's an airway abnormality. I
wonder how much that's contributing.
I don't know. Yeah. Yeah, there was some airway abnormality down here. I don't know. Don't know the answer to that. Okay, let me show you this one. So let me bring up just the chest radiograph, and I'm going to intentionally hide the sidebar just for the moment and give everyone a moment just to look at this case and see how you would analyze this case. As you look at it, I will tell you that the findings that are present are not associated with symptoms as such, but just are some interesting imaging findings. So take a look at vessels in the lung, vessels in the mediastinum, and other interfaces. It's kind of acute cases you'll see. Let me now bring up the CT, and I'm going to put it alongside, and I'm going to make this one, again, just for illustration purposes, look like a chest radiograph. And I'm going to do that, and I'm going to do that, and make it a thick slab so we can take a look at that. So I think this one is really nice in looking at the bronchi and trachea and the relationship between these bronchi and the appearance of them in relation to the corresponding pulmonary arteries. So here on the left side, we recognize the usual anatomy. Our left main bronchus, it is beneath the corresponding pulmonary artery. But on the right side, now that we have this in particular, you can see we have very similar anatomy. We have this relatively long bronchus, and we can see that it is underneath the corresponding pulmonary artery. So both of these bronchi are hip arterial, HYP, hip arterial bronchi. The other observation is this thing, which is a distended azygos vein. We'll get to in a moment. And the other relatively subtle finding on the frontal radiograph is that there is a mediastinal lung interface that parallels the spine. It's pretty subtle. You can see it here, kind of disappears up there, but you can see it right there. So in terms of, if you see this and you're lucky enough to see, for example, the airway abnormality, then the notion of tracheobronchial situs comes into play. So this is something that I keep on my laptop when I have trouble, because I can almost never remember this. And if I think I have an abnormality there and I go down the right side here, concentrating on the airways, if I get to the point where we have bilateral hip arterial bronchi in this box, then of course we're thinking about polysplenia. and that's tracheobronchial. So now I will take this away from the coronal here and go back to the other to show you that, yes, we have azygous continuation of the IVC. We have polysplenia. So that fits really nicely. So we have the tracheobronchial situs abnormality and the associated polysplenia. Azygous continuation of the IVC is present. And this, you can see, was just all clarified in the context of a study for PE. So a really nice example of that imaging finding. And this is a cute radiograph to test those observations on. That's kind of cute, I think. Little subtle findings.
You have a lateral view.
Lateral view?
Sometimes you can see the hypoarterial bronchial arrangement on lateral view too. So there's not much pulmonary artery in front of the left main bronchus there, not very much there. Sometimes I've seen two contours posterior to it when there's this left lung isomerism. So the left PA is arcing over the top of that bronchus and going behind it. Sometimes you'll see two shadows there for the left and for the additional right one.
Yeah, I don't think I don't have experience. I mean, we don't see too many of these, so I'm not sure that I pick up on that.
Yeah,
just on the basis of the lateral. Yeah,
very cute.
Yeah, nice.
So also staying with the lateral view here, there was an argument in the old literature about the absence of the posterior wall of the inferior vena cava plugging into the right atrium at the bottom near the diaphragm. So you can see that interface back there. People said, okay, if there's azygous continuation, we know that the inferior vena cava is absent, and therefore that shadow down there does not exist. And so they would show examples of that shadow.
So you won't see the
it still exists
face on here.
It still exists, but they said it doesn't exist because it can't, because we know the IVC is interrupted. So they would ignore the finding on lateral.
Yes.
It's not there. And the reason it's there is
the
suprahepatic cava is indeed present and plugging into the right
Sorry,
atrium.
you're breaking up sometimes.
Okay.
The usual convex anterior interface of IVC there. Right. Can you folks still hear me? Do I have an internet connection problem, or maybe David?
Howard, I think it's yours, and it's very mild.
Okay. So yeah, David, that's a great observation. If you think that might be going on, you look for the IVC up here, you don't see it, and it's an additional point. Great.
Well, the thing is, we do see it, but people said we shouldn't be seeing it, and therefore we're not seeing it even when it was there, as in this case. So you do have it in this case. It's a little anterior to your arrow, and that's because the suprahepatic inferior vena cava is still present.
Right.
That's what generates
the
interruption is below it. Yes. Yeah. So that's still going to be visible on lateral view, but they said they misunderstood where the cava is absent, and they said we shouldn't be seeing this contour that we see, and therefore we're not seeing it.
Yeah. Okay. Okay, here is the next case, and then Jeff, I can show more cases, but let me just stop after this one. So this is a radiograph from 1999, and I'm going to zoom it up so you can focus into the finding. So there is an abnormal opacity that projects superior to the aortic arch on this frontal projection. We can see that its interface with lung, where we do see it, is quite smooth. And then internally, we can see calcium, so abnormal calcium in that location. So that is 1999. And I will show you CT from 2008, in which case you can see this has grown substantially, but otherwise in the same location and with the same imaging features generally, but just much bigger. Here is a CT from 2008, and you can see the size of it. You can see the nature of the calcium or matrix of calcium and or bone in this lesion. So going to the bone, certainly over here, it's close to the vertebra. I don't know if any of you think that one can conclusively say with confidence that it's clearly arising from this vertebral body for sure, because this is a chondrosarcoma of mediastinum, and that's certainly been reported. I can see the contiguity there. I don't know if it's actually arising there or not, but it's certainly hard to separate out in that particular location. But this was, a debulking was attempted, as you might imagine, that wasn't entirely successful. So this unfortunately continues to grow, and it looks like that the person's had a stenotomy. And the entity of mediastinal chondrosarcoma has been reported, as you can see there. And this is certainly very consistent with an example of it in the chest. It's kind of a moot point, obviously, as to whether it really came from that vertebra or not, but it's certainly pretty close. But the epicenter is a little bit away from it. Well, at least it's quite large there. Any additional thoughts about this other than just an unusual case of a mediastinal chondrosarcoma?
Howard, does the article imply that they're always associated with bone, or sometimes, or can they just be
I think that
without being arising from bone?
Yeah, I think that there is a comment here, if I can get to it. It says a typical manifestation of chondrosarcoma, albeit in a rare location. Differential diagnosis is extensive. Although chondrosarcoma is rare in the spine, it should be considered. I'm not sure.
Okay. I mean, the underlying vertebral body looked pretty unperturbed in this case, implying to me that may have been contiguity rather than arising from the spine.
Yeah. Yeah. Hard to say, isn't it?
Yeah.
All right. Jeff, should I continue and show another one or two?
Let's see if Brent has any cases. If not, then
All right.
Brent, are you there? All right, well, continue on, Howard.
Okay. I'll show this one. I don't have pathologic proof. I'm going to bring up the MIPS and the thin cuts alongside each other. And just to initially scroll through the MIPS, if this happens to be the first series that you look at, you can appreciate, in this case, it's a 10 millimeter slab, that something's wrong. There are lots of little nodules there. So it's clearly a kind of diffuse nodular appearance. And here is the corresponding CT that goes along with this case. So I'll scroll through there, zoom up a bit, and give you a feel for what these nodules look like. I certainly would describe them as centrilobular ground glass attenuating nodules. And usually if I think centrilobular ground glass attenuating nodules, I think of hypersensitivity pneumonitis. Perhaps you'll agree that they seem to be very numerous in the upper lung zones rather than the lower lung zones. And there was nothing in the clinical history to suggest the possibility of hypersensitivity pneumonitis, but a strong smoking history. So because of that in the appearance, I reported this as likely a case of florid smoker's macrophages, as in florid respiratory bronchiolitis with the centrilobular nodules of it. Anyone think that is all right or unreasonable as a provisional clinical and imaging diagnosis?
I think it's the best diagnosis.
Yeah.
That's pretty nice.
It's pretty florid, isn't it? I mean, I see it sometimes kind of subtle, but
right, yeah,
that's pretty.
A little bit sharper. And what's also nice is with HP, besides that they're symptomatic, is that it's much more diffuse. And these, like you said, can you make a coronal to show the distribution?
Yeah. Let me make it just a little bit thicker so it's not quite so noisy. And bring this down to around about 2 to 3, maybe, something like that. Scroll through there. So
yeah, that's really nice. It shows the gradation.
okay, yeah, I think that's very likely what this is, as fairly striking imaging finding, albeit unexpected. All right, let me show you this one. This is a pretty dramatic case. So there's a long history here. So let me just bring up initially a chest radiograph, and I'm also going to bring up the history along with this. So this is a person, also just to remind myself, you can see the history here of this person with tetralogy, or pulmonary atresia. When she was 9 years old, you can see that they did initially a form of conduit, perhaps a stented conduit. I'm not personally familiar with something called the Prima conduit. I think it's made by, I can't remember what company, but she had this conduit in 2008 with subsequent Melody valve implantation, presumably in that conduit, in March of 2015. So on this radiograph here, we can see findings that go along with that congenital heart disease in the right side of the aortic arch. We can see the Melody valve. You can look at the ultrasound report here, and you can see there is a problem with the patency of the Melody valve. There's a gradient across it, as well as an abnormal opacity seen within it. And I will show you that now. So let's see if I can pick out the right series to show you the pretty large finding in relation to the Melody valve. So let's see, there it is there. And as we go higher, you can see this large filling defect. Sorry, let me just show you in there, in relation to that Melody valve, that goes along with this ultrasound finding consistent with thrombus and or vegetation, or combination of the two, but certainly thrombus really blocking off that valve. Let me show you another CT, if I have it, of the same finding in relation to that portion of the valve. Change that, and you can see it's actually pretty extensive, isn't it, in relation to that valve. As you can see here, they had to operate on this patient. They were able to extirpate the stent in the valve, grossly abnormal with massive thrombus inside. They removed the conduit that was there as well, which I can't see. And let's see if there's anything else. Maybe that's all I have. But yeah, but a pretty dramatic and unfortunate occurrence of thrombosis in the Melody valve, and a question of endocarditis as well. So they took that off, and they just did I think a homograft to replace that part. I think that I have shown you all the ones I have.
All right.
No, wait, another one. Is another one. Do I have time? Anyone else?
Go ahead. I've got a few more I can show after.
Okay. Here's a patient that had surgery, spinal surgery. And here are some first radiographs over time. So here on the 20 of March, looks like that. This is the 22nd of March, and you can see that the dominant finding is accumulation of right pleural fluid. So that is a big finding on the radiograph. They were concerned about, and they presumably tapped some of the fluid, and then became concerned about a communication between the thecal sac, the spinum, and the pleural space, as in a leak. So they did a number of imaging exams, and I have to try and pick out the one that shows the location of the leak and the contrast medium going into the pleural space. And just give me a moment to try and pick out the one that I found that I think showed it fairly nicely. So If we go up high here, at least at this part of the exam, you can see this is high attenuation. So that is contrast medium. And they described the leak, and then they put a chest tube in. So they described the location of the leak as being fairly close to where the pleural drain is. So let's see if I can find that. Okay, so here is a pleural drain right there. And they described seeing that there was some contrast communication between what you see here and tracing it in towards the spine, but they diagnosed the leak at that level. Maybe an image like that is where we can see this contrast medium here close to the pigtail catheter and then going in that direction in the pleural space. But that is indeed the case. Let's see if I have the op note showing you, as you can see here, the dural defect was identified on the right near the T10 pedicle, and they went ahead and fixed that. So a spinal or CSF communication to the pleural space is a complication of that spinal surgery. Okay, Jeff, there you go.
Wow.
Right. All right, let's see what I can find here. Okay. All right, we should see a CT. So this was a motor vehicle crash. And, to go along with Howard's earlier case, you can see there's been some trauma to the left hemithorax. What's interesting in this case, and there's a little splenic injury, what's interesting in this case is the location of this injury. So there's some rib fractures, subcutaneous gas, and sort of the left lower chest wall out laterally, and then this sort of gap here in the musculature here. And so this is actually a diaphragmatic defect that was confirmed at surgery. It was about a 13 centimeter defect. But interestingly, they saw it up high as well. So I wonder if it was just the position. They ended up doing a splenectomy because there was bleeding at the time of the surgery. But you see the diaphragm is elevated, but up at the dome, it's pretty intact. We don't see any herniation there. So I think this is sort of a low-lying lateral diaphragmatic defect, and we just catch a portion of it on the chest CT. So it was presumably torn from a combination of rib fractures and blunt trauma. A little bit of an unusual location for a diaphragmatic defect. And I wish they took some pictures intraoperatively, and he had some bleeding in the mesentery as well, but it sort of formed this hernia between the ribs out here. So and there's the radiograph of when he came in. So you see the subacute gas, the fractures down here, but a normal contour. So usually we're looking up here, but there was an apical cap tipping off at least that something was abnormal in this patient. But I'll throw up a coronal as well. But and it sort of, to me, it seemed I've lost my coronal buttons, but for whatever reason. It's still loading, that's why.
Probably tore the diaphragm away from its chest and abdominal wall mooring out laterally.
Yeah.
So you probably tore it out there along with the chest wall and abdominal wall being torn.
Yeah. So sort of a lateral injury. So that was just an unusual one. I'll send that one along. And then this is just a follow-up of Julie's case that she had sent. I showed a couple of weeks ago, I think. So this was one I looked at. I can't remember why, totally unrelated, but I was immediately struck by these tracheal nodules. Oh, you're not seeing them. Hold on. There we go.
Don't see your case yet. There we go.
So as I started looking through this case, I immediately was struck by these broad-based nodules, primarily along the anterior wall of the trachea. And having seen this enough times, I recognized what this was, and it looked a lot, not quite as exuberant as Julie's case, but still pretty good example. We see these nodules along the cartilaginous portions of the trachea. So I confirmed my suspicions with a virtual bronch, and you can see all these what look like submucosal nodules going all the way down here. So I think this is another case of tracheobronchopathia osteochondroplastica as an incidental finding. And I've seen them very subtle cases, not infrequently, particularly in smokers, but this patient And I believe this patient was a smoker, and I think this was a nodule follow-up. But I thought these were quite impressive and looked sort of like this.
But not associated with calcification or bone or anything within them? Just
not in this particular one, no.
Was this a male or a female? I didn't see on the...
It was, let's see, it was a male. No, I take it back, it was a female.
Do you think that TPO is more common in females?
I think it's more common in men, but women, in my experience, women tend to calcify their cartilage earlier and more frequently than men.
Right.
Same with the ribs.
Yeah.
For whatever reason. Okay, and then this last case, I came across. This is a young man. He's actually, let's see, let me show you the screen here. So he is incarcerated for some time. This is an old study for something at some point. Carried a diagnosis of asthma and developed sort of acute hypoxia and shortness of breath. And this was his presenting chest radiograph. You can see there's multifocal lung consolidation. Here's the lateral. You see a really nice demarcation of the upper lobe. Nothing that looks pleural. It has a normal heart size. So obviously infection would be high on our list. Some sort of drug toxicity, but as far as I know, wasn't on anything for his asthma, but had been other than inhalers, but had been having some trouble. So he had a CT that same day, which kind of just shows the same thing, this extensive consolidation, ground glass, with some interposed normal-looking lung, and sort of this nice peripheral sparing. So it looks very organizing pneumonia, maybe given the asthma, an eosinophilic pneumonia picture. Well, he underwent further workup and actually had elevated ANCA, P-ANCA was elevated, and then had he had chronic sinusitis and an eosinophilia. So this diagnosis was at the time called Churg-Strauss and is now eosinophilic granulomatosis with polyangiitis. But this is one of the worst cases I've seen with lung involvement. I've seen patchy ground glass, some septal lines, but this one looks... And so he presented primarily with lung symptoms. As far as I know, there were no neurologic symptoms at the time, but the rheumatologist back in 2012 decided that he met criteria for EGPA.
So based on the lung disease, the sinusitis, the
asthma,
asthma,
and eosinophilia. Yeah.
Yeah, I don't know if the criteria have changed, but they give points for different things. And if you get so many points, you can make a presumptive diagnosis of that.
Right.
And then he had an ANCA positive as well.
Correct, the P-ANCA.
Okay. Wow, that's pretty impressive.
Yeah, this is the most impressive one. And I came across it because we were doing a file. I mean, he responded to treatment and stuff, so it goes away. But so a lot of this probably represents an eosinophilic pneumonia, for lack of a better term. Usually responds to steroids. But there's a couple. I think there was a paper from Vancouver that looked at the findings in these patients, and they talk about septal lines consolidated, sort of the non-specific stuff that looks like more of an acute type injury that's overlaps with OP, EP, and they describe some septal lines. And I guess they can get some cardiac involvement, so there may be a component of edema in some patients. But this guy has a few septal lines, but it seems to be in areas of other things going on. So
yeah, the cardiac involvement is very distinctive for this syndrome. And the other thing that they frequently have is peripheral neuropathy because of attack on the vascular supply to the nerves.
All right.
Yeah, that would be classic. You get one big point for your mononeuritis.
Right.
Yep. Good.
Okay. Well, that's it this week. Thank you, everyone.
Thank you.
All right.
Great cases.